We'll start our new year here, and a happy new year to everybody, although it's near the end of January, but I think we're all seeing daylight again, I'm hoping, in the coming few years. And it's also the new year of the Chinese calendar. It's the year of the tiger, in case anybody is part of that zodiac. Well, it's not really a zodiac, it's the Chinese zodiac. So welcome again to our first meeting of the year, and we'll have Mark call the roll.
Sure. Commissioner Green
Present.
and Commissioner Chow.
Present.
And then I will read the land acknowledgement.
Yes, thank you.
Sure. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community, and by affirming their sovereign rights as First Peoples. Dr. Chow, would you like me to call the items, or would you like to call the items?
No, please call the items. I think on a remote program, it's much easier.
Sure.
And more organized. Thank you.
Of course. Item 2 is the approval of the December 28, 2021 minutes.
So we'll need a motion for approval.
Move to approve.
And I would second, so I think that takes care of the minutes, right?
Yes, sir. We can move on to item 3, and I'm noting there's nobody on the public comment line.
Oh, yes, thank you.
Sure. Item 3 is the regulatory affairs report.
Good afternoon, Commissioners. I'd like to introduce Daphne. Daphne Wayne is the new Director of Regulatory Affairs. She was promoted in November of last year. She was a member of the team for around 3.5, almost 4 years before that. I'm looking forward to working alongside her in the forthcoming months and years and seeing her grow and develop into her role. I'm sure you're going to enjoy hearing Daphne's perspective on licensing and certification and the regulatory affairs report. Of note, she was a CDPH surveyor for several years before joining our team here. So she brings a really unique insight into the work that we do from a regulatory perspective. I do also want to point out that we were excited to bring some graphs and tables to you in December. We heard your feedback and we're beginning to assimilate that, but unfortunately, our analyst has been unexpectedly out on medical leave for most of this month. So you will see the return of our graphs and tables in the February report. And I'll hand over to Daphne.
Welcome, Daphne, and we'll be careful about what we say about CDPH now.
You're on mute, Daphne.
Daphne, I'll unmute you. There we go.
Hi, good afternoon. I said that's okay. I probably heard it before, so thank you for the opportunity to present today. Pending surveys, we continue to anticipate the Joint Commission lab accreditation survey. Also, both CMS surveys for 4A long-term care, the recertification, and our fire life safety. And we also continue to anticipate the dialysis recertification survey. For completed surveys, the first one we have OBOT by DHCS. It was closed with 2 deficiencies, and I'll provide more information in the completed survey summary section. Of the 7 completed case investigations, 7 were closed. All 7 were closed with no deficiencies. Also closed was the COVID mitigation survey for 4A with no deficiencies. And our licensing survey for the rehab space was approved, and happy to say that they've moved. So congratulations to them. Of note, so surveys are typically independent and don't necessarily impact closure of case investigations such as FRIs, privacy breaches, and complaint investigations. What has helped accelerate closure of more cases this time was actually deferral to Joint Commission, who does have an accelerated process. And also a push from Sacramento to close out their backlog for each district office. However, we haven't been privy to any information on new measures for their existing process, except possibly having administrative closures, which is done in the office. And we just provide the information mitigating an on-site investigation, which can take a little longer. We have no plans of corrections for this report out. Section 4, open site visits. So there's been a lot of activity. I've bolded the cases that have had recent activity, just let you know that they have a focus. They've been focused on recently. Section 5, new facility reported incidents. So we had an allegation of abuse lodged by a family member for a patient. Use of force on 7L, and we're collaborating with the Sheriff's Office and Director Price for that one. Elopement from the ED. Patient-to-patient sexual assault on 7B. And my apologies, there's a typo. The privacy breach was regarding unauthorized disclosure by a staff member on H32, not access. For a completed survey summary, corrective actions for the OBOT DHCS survey include daily monitoring and reconciliation to address potential discrepancies regarding methadone, and also ongoing QA and overview to assure that the correct number of urine samples are collected per year and to address any challenges. And this action plan was approved by DHCS. I can help with any questions.
Commissioners, there is one person on the line, so I'm going to just check for public comment. Thank you, Daphne.
Yes, please. I'm just going to ask that. Thank you.
Sure. Person on the line, if you'd like to make comment about item 3, the regulatory affairs report, please press *3 now so we can recognize you. Again, *3. No hands, no hands, commissioners.
Okay, so we'll go on for comments, and for some reason I've got new logos again on the hand thing, so you'll have to watch out for me if other people have raised their hands, okay, Mr. Morwitz.
See any hands now at the moment, Commissioner?
Any comments? Dr. Green?
I don't think she has any.
I guess the only question I had is I noticed that, I think I might have written this, I noticed they cleared quite a few things quite quickly. And I wondered whether that's a good sign, an anomaly because they were here doing other things. In other words, we've watched the, the surveys and the fries in both our institutions be so delayed. And I wonder if this means we're on an accelerated path or this was just kind of a one-off.
We hope it's not a one-off, and it is a good sign that they're actually closing out cases. So they don't have any additional measures to their current process, so it depends on if they refer more to Joint Commission, but, it's hard to say at this point since there's not a new measure to their process.
Thank you.
Thank you.
Yeah, and thank you. The bolding was really very helpful to be able to spot the new activities. So really appreciate that. Shall we go on to the next item then?
Yes, sir. Daphne, congratulations on your first report to the JCC.
Thank you.
Item 4 is the ZSFG Chief Executive Report, COVID Surge Update, and Emergency Department Newsletter. And Commissioners, Dr. Day will be showing a presentation during this item at some point.
Good evening, Commissioners, and I think I'm going to start per Dr. Ehrlich's request. So I will go ahead and share my slides. Everyone able to see these okay?
Yes.
Yes.
You can make it a slideshow, go to slideshow and start it. So that, yeah, there we go. Perfect.
Good afternoon, Commissioners, and Happy New Year as well. Given sort of the recent Omicron surge that we've been experiencing across the United States and here in the Bay Area, we wanted just to provide you a very brief high-level overview of what we are seeing here on the ground at ZSFG and how we have been addressing this current surge, which is much different than I think all of our other surges that we have seen before us. This slide here, it's already a little bit out of date, but this gives a very nice representation over the last 2 months of the number of patients admitted to ZSFG with COVID-19. And what you can see is really right around Christmas Day, we started seeing a very large precipitous increase in the number of patients admitted to Zsfg with COVID-19. And this number has peaked really around the mid-60s. This is as high, if not higher, than our last surge almost a year ago during the same time. And this is very much what we have seen across the rest of the city and the Bay Area. Just as sort of where we are currently, we still continue to have about 60 patients admitted to the hospital with COVID-19. So we've not seen a decline in these numbers yet, although we do think we are at the crescent of the current surge. We have seen that about half of the patients admitted to the hospital are asymptomatic and admitted for another reason, but incidentally found to be COVID positive due to our testing. And that only about 10% of patients admitted to the hospital are fully vaccinated and boosted. But of the patients who are admitted to critical care, the vast majority are unvaccinated patients, which again very much correlates with what we've seen through the rest of the country during this current surge. The other thing that's sort of coupled on top of this surge that we have not seen with others is that this definitely impacted our staff. At one point, close to 20% of our staff were out, either due to having contracted COVID, being exposed to COVID, or potentially having symptoms that were COVID-like. And so this definitely had a significant impact on our operations across the entire network and also our campus as well. So how did we address our current surge? Well, one, we followed our basic principles that we initially developed nearly 2 years ago. And just by way of history, when we first developed our surge plans, we had built into it that a large majority of our staff actually might be out with COVID-19, anywhere from 10 to 20%. We never realized those numbers over the last 4 surges. And it wasn't until this current surge that we actually had to implement some of the countermeasures we initially thought we might need. And so we always felt it really critical to have principles embedded in our surge plan. I think this was easy to communicate to our staff, but also to all of our teams and to our patients, really what were our key ideas in terms of how we were going to move forward and prepare for COVID-19. And so it falls into 4 key principles that we call them the 4 C's. The first is we cohort patients on our inpatient unit. So we cohort them by areas, whether it's med-surg, critical care, labor and delivery. Within each of those cohorts, we have care teams, so small dedicated care teams that care for COVID-19 patients, which usually consist of specific MDs, nurses, and respiratory therapists. This allows for several things. One, it allows for best practices to be implemented when caring for these patients. It minimizes the number of people going into patients' rooms. And then also these care teams participate in daily multidisciplinary rounds to really follow a comprehensive approach for how we think about caring for, but also discharging our patients once they are ready to go home. And then the last 2 are around capacity and containment. Capacity just refers to ensuring that we have enough beds in the hospital to care for our patients during these surges. And the last is containment. So really trying to minimize the number of people really coming onto our campus, but really trying to minimize the spread of COVID-19, both among staff, but also our patients. So with these 4 principles in mind, each of our key operational areas created their own surge plan over the last several years. And I'm not going to go into the detail of each of these surge plans, but just to kind of give you a flavor that our ED, our family health center, or our labor and delivery unit, our med-surg, and our critical care teams all had surge plans very much built upon these 4 C principles. And I sort of have at the top that these are interconnected, unified surge plans. And so with that, we created a comprehensive ZSFG campus-wide surge plan, which you have here. It's a much more detailed report, but this gives a very high-level overview of how we approached COVID-19 and particularly surges here on campus. I really want to highlight 3 things on this slide. First, starting over on the left hand, we followed a color coding tier system to indicate various levels of where we were at for a surge. These levels were based on both the number of COVID-19 positive patients who were admitted and people who were under investigation for COVID-19. Based on each of these tier systems, we then go into the various columns, which represent our operational areas here on campus. I'm highlighting some of the key ones, such as urgent care in the ED, critical care, our outpatient and perioperative area, and our med surge. Other areas that are not represented here include our radiology and other ancillary services as well. And then within each of these rows, within each of these colored tier systems, we follow those 4C principles, really, again, trying to deliver the best care to all of our patients, while at the same time maintaining safety for our staff and maximizing capacity of hospital resources. So where are we currently at based on our current surge level? So I showed you on that initial slide that we are at about 60 patients admitted to the hospital with COVID-19. So that puts us at a level red. We've been at a level red probably for the last week, and we anticipate we'll probably be at a level red moving into next week as well. So what does this mean for our hospital system and really for the ZSFG campus? I'm going to walk you through each of these key operational areas, just giving you some highlights of what we're currently doing here on campus. So on our inpatient unit, our 6th floor here, which it has been for the last 2 years, is our COVID unit. And we have 3 dedicated attending-only services that are caring for our COVID-19 positive patients. Also, at the same time, we've expanded some of our other medicine teams here to help provide additional support, since our number of non-COVID patients has not decreased during this time period. Similarly, in the ICU or critical care, 2 of our units on the 3rd floor are our COVID-19 ICU units, and we have 2 dedicated attending-only ICU teams caring for patients. Our ED and urgent care have prepared developing separate triage areas for respiratory patients. They've extended hours, and they've also began to cohort respiratory patients in specific areas. And then really what we have done is really try to create more capacity here on campus. One, given our staffing shortages, and also just trying to make sure that the number of patients coming into the hospital is at a lower level. And so we focused on some of our outpatient areas. Specifically with regards to our outpatient clinics, we are now only seeing urgent patients here on campus. So all of our non-urgent outpatient appointments have been rescheduled, and our goal is to be under 50% of baseline in-clinic visits. We've mostly transitioned to telemedicine or telephone visits during this time period. And then secondarily, for our perioperative and procedural areas, we have now significantly reduced our common stay surgeries to just under 8 per week. This is reducing the number of admissions to the hospital. And then also, very much like other systems in the city, we are only, again, doing emergent or urgent surgeries or procedures, which is defined as having to need to be done within the next week. And we've reduced our OR volume by 50% over the last week. We are hopeful that potentially over the next couple of days, at least in our outpatient setting, we can actually scale back a little bit, especially as we start seeing some of our numbers of COVID positive patients decrease and the number of staff who are out returning back to work. With that, I am happy to answer any questions. COVID-19 and the current surge here on campus.
Thank you, Ed. Mark, will you see if there's any public comment?
Sure. Folks on the line, if you'd like to ask any questions about the COVID update, please press *3 now. *3. No hands, commissioners.
Okay, so very extensive and well thought out plan. Thank you. Commissioner Green, any questions?
Well, I think this is such an impressive plan for its intricacy and thoughtfulness, and I'm obviously quite impressed by what you've done and how you've been able to pivot and really address this completely unanticipated aspect of the staff being out to the extent that it has been, with such alacrity. I'm really impressed. I was wondering, one of the problems we've had is when patients come to register, it's like this big group of people. And I'm wondering, whether you found ways to kind of segregate people at the door so that, it always takes time to do that input. And I'm wondering what kind of ability you've had to segregate people from the get-go so that you don't have people waiting, given Omicron's aerosolization with those who might be there for other things. And then how you anticipate our statistics for urgent care to ED, how you think that'll flux based on these extended hours.
Yeah, excellent questions. To your first question, patients who are checking in both in building 5 and in building 25. So one, we ensure that everyone's wearing a mask when they come into the hospital. We also try to maintain social distancing between all of our patients as well. Again, really trying to minimize that risk of exposure to COVID-19. Additionally, when they come into the building, we try to do at least from large scale signs, ensuring that no one has respiratory symptoms when they're coming into the hospital. And if they are, they actually are triaged by our urgent care center in the check-in area. So if someone comes in and says they may be having a fever or coughing, they will actually be shuttled over to our urgent care triage area within the check-in space. And then they'll undergo an evaluation there. And if need be, we'll actually either go to their appointment or go over to urgent care for more evaluation. This has actually worked quite well. I think usually we don't have a lot of lines queuing. Patients are able to move through pretty expeditiously. And I think it has also helped with wayfinding as patients check in down below and then are able to give clear directions to move up to their specific appointment times in the specific clinic locations. Excellent question around urgent care. I think we could do a whole presentation on just, I think, the phenomenal work that urgent care has done over the last year and a half around the pandemic. I think it's really a testament to their leadership team of Mirja Roca, Ron Labugan, Carmen Liang. They've done a phenomenal job with their frontline staff, really being nimble and flexible and innovative about addressing the pandemic. So they developed this urgent care triage center in the check-in area. They've really streamlined the workflow between the ED and urgent care of handing off patients. And this has significantly decompressed our ED, which has been quite busy. And in fact, I think most days now, if you were to look at the numbers, our urgent care is seeing a similar number of patients as the emergency department is. And so I think this has very much helped flow within the ED, especially since we've had a higher number of boarding patients over the last couple of weeks. But I think, they've done such a great job of, developing standard work in terms of which patients should be transferred over. They've developed a very robust communication schema. And also they've developed, I think, a lot of confidence in the ED staff to actually feel comfortable sending patients. So I've been to several ED huddles where they've commented on really utilizing this service a lot more and feeling much more comfortable in sending patients over to the urgent care center to be evaluated.
That's fantastic. Do you have a crystal ball? Of course, all of us do, on when you might be able to step down from red? I mean, we see these numbers, but it's different when you're dealing with a hospital-based population.
Yeah. One of my mentors gave me an adage of if I try to prognosticate, I will actually eat broken glass, of trying to look into a crystal ball and trying to sort of figure out. And that has been true for, I think, most of all these surges. I will say, one, what's reassuring is that the number of new cases in the city has declined and has declined pretty significantly. Our case positivity rate has gone down from about 20% to about 17%. And we know hospital censuses kind of lag behind that by about 1 to 2 weeks. So we think we're probably at our crest right now, and we should probably see our numbers declining. We think probably within the next week. We're anticipating by next week we'll probably be at a level orange, and we're planning to reopen more of our specialty care and our perioperative outpatient services by then. I think one of the things that's really hampered us is that we've had staffing issues, but a lot of our placement options, our skilled nursing facilities have had a lot of staff go out, and with COVID outbreaks there, many of them have been closed. And so that has delayed, I think, patients being able to be discharged in a more timely manner.
Thank you. Although I noticed our lower level of care numbers aren't terrible. I mean, I expected them to shoot through the sky, and they're not that bad.
Just wait until next month.
Yeah, I was going to say, wait till February. Unfortunately, it's not without them doing great work and really trying, but yes, unfortunately, they will probably creep up.
Oh dear. Thank you. Commissioner Green, are you any further questions?
Oh no, thank you so much.
Okay, thank you. I was just very curious on two things. If part of the reason for coming in was not COVID, but you found them COVID, do they still go to the COVID wards? And then it looks like, how do the people who were going to take care of them for whatever it was, might be elective or might be a procedure of some sort, then take care of them on the COVID ward? Because the way it reads, it sounds like you have dedicated teams there.
Yeah. So to your first question, it depends on how many COVID positive patients are actually coming into the hospital. So at levels green, yellow, and probably even orange, we could cohort almost all patients who are COVID-19 positive in one area, regardless of symptoms or not. Once we get to the level red, we had to be a little bit more judicious. And so we started cohorting patients who were symptomatic and were really there for primary COVID-related reasons on the 6th floor. In addition to the teams, we have 3 dedicated teams that are caring for those COVID-19 positive patients who are symptomatic right now. These are our FIS services, which are attending only hospital services. And all of these individuals have cared for COVID patients throughout the pandemic. They're the ones who are also going to the daily multidisciplinary rounds with our infection control and infectious disease specialists. And so they're very well up to date on all of the best practices, care for our COVID-19 positive patients. And then also the nurses on the 6th floor are the same teams as before that have cared for COVID-19 patients. The asymptomatic COVID-19 positive patients, we have pivoted a little bit. So example, if I came in with a heart attack or a stroke and that was my main medical condition, I would remain on the team that would need to provide me that primary care if my COVID was not active. And we felt that this was probably the best practice just to help sort of distribute patients more evenly across the teams and really to focus on what the patient's primary medical need is.
Thank you. I know we touched on this earlier when CDC came out with their new a guideline in terms of staff coming back. I mean, it's somewhat alarming to hear 20% of our staff was in some way impacted by COVID. So as you bring people back, patients have felt, you know, that they might be uncomfortable if staff did have active COVID. Do we check the staff before they go onto the floors that they are then negative, or do we still allow them to work if they're positive?
Yeah, excellent question again. We also, I have to also commend our occupational health team, which has just done a phenomenal job of really being up to date on the new CDC guidance, which has been changing. And some of it is counter to what California Department of Public Health had also recommended. But they have been very thoughtful in working with infection control about how to ensure we have a healthy staff that can return back to work, but also that it's safe for patients. So one thing that we instituted early on in the pandemic is that all staff, when engaged with patient care, have to wear an N95 mask and also wear eye protection. And so that definitely, I think, provides reassurance for both staff and patients. And then with respect to our return to work guidance, a lot of it depended on, 1, do you have symptoms? And then 2, were you exposed to someone who had COVID or not? And was it in your household or was it potentially at work? And based on those various scenarios, you would undergo testing and you potentially might undergo more regular testing, either before going to work or before starting a shift. So we had a very robust and continue to have a robust system set up on campus of 2 different clinics where staff can go and get tested, and in many cases can actually drop in and get tested if they need to be.
So
just to add to that, Dr. Chow, the California Department of Public Health allows basically people with COVID before their isolation period to come back to work, but we have not done that. We are more conservative than the California Department allows for, and that's the balance that we've been striking between getting as many people back to work safely as we can and taking advantage of regulatory guidance. So nobody, if you have a diagnosis of COVID, nobody comes back to work before 5 days, and then it depends on your testing and your symptoms between days 5 and 10. So we're trying to walk a balanced line.
Sure. So if someone then had a reduction of symptoms, would we test them for COVID upon them coming back after, say, 5 or 7 days? And if
Yes.
that were positive, they would not be at work?
Correct.
Okay. I understood that from our previous comments in the past, but I think that's the reassurance public really is concerned, right, about. Even though everybody has their masks and whatnot, to be concerned as to the caretakers. And sounds to me like you've all appreciated that and have been very thoughtful in how to bring our staff back. Thank you. Does anybody else at this point from our group here want to also add anything in regards to anything you might have been doing, or find exceptional that we should hear about?
Well,
Sure.
I believe Dr. Ehrlich is going to go ahead and do her report. Dr. Day was just doing the COVID update. Is it okay if she goes ahead with her part of the item?
Sure. No, I think that'll be fine. And if, like I said, it's unfortunate we don't have our table because it's always nice to hear comments also from the remainder of the staff. But Dr. Ehrlich, why don't you proceed?
Sure. Well, first I want to just really commend Dr. Day for his excellent presentation. He covered a lot of what we've been doing during this last surge. And I just wanted to say, how proud I am of our team and how uniquely challenging this 5th surge has been. And the reason for that is not because we don't have incredible surge plans that we are now quite well practiced at, but I think there are 2 things that make this surge really unique. One is just how many people it affects and the impact that it's had on our workforce. That is just leagues beyond anything that we've encountered or dealt with before. And second, the fact that it comes at the end of 2 years of dealing with this pandemic. And, our staff is remarkable, and just in virtually every area of the campus have really, gone above and way beyond what anyone would have expected. But it's hard. And so, supporting one another and making sure that we're still, all in this together and working, it gets harder as time goes on. So I just want to point that out. I think it's probably obvious to you. And it's something that we need to have constant vigilance about, is taking care of our workforce, because they're clearly our most important asset. Luke covered a lot of the surge plan. I tried to summarize it in bullets on the first page about return to work guidelines, which we've covered, the surge plans, which Dr. Day very well covered. The other feature is about discharges. And because I think so many people have been impacted, that has also impacted the places to which we discharge. So I'll talk a little bit more about that when we get to the lower level of care numbers, but that has also been a unique feature of this particular surge it's hit us harder actually than previous surges. Visitor limitation. So basically we don't have visitors now except in very unique circumstances. So that would be people who are laboring, people who are end of life, and children. And this is, of course, to protect everyone on campus. We've been really pushed, especially a couple of weeks ago, to provide testing for the community. Specifically our network patients, and have done unprecedented numbers of tests, beyond 500 a day in some cases, which is also well beyond what we did in previous surges. So those are the areas that we've been working on. And of course, I just wanted to point out that it was only just over a year ago that we vaccinated the first people in the city of San Francisco. And it's just tremendous to think about all that's happened since then and how much those vaccines have really protected people in San Francisco. especially those who were boosted, and has really helped save us, I think, in the hospital during this time. So just on the COVID positive patients, I wanted to make a point about the numbers. So the numbers that you see in the graph here are only people in the ICU and med-surg. There are we have patients in OB, we have patients in psychiatry, and a few on 4A. So these numbers that you see here are slightly lower. But it's interesting to note that our high water mark for patients in this year on January 20th of 2022 was 69. And it was a year ago on January 19th that we had our highest number in the winter surge, which was 67. So very similar numbers at very similar times of the year, almost to the day, which is quite interesting. You can see that our emergency department volume has been going up. You'll see it even higher in January. So the average daily will be, well, right now it's running at about 163, which is standard for January, and it's harder with COVID. The diversion percentage, Dr. Green, you commented on, and I have to say that I looked at these numbers again because the truth is that in January to date, we're running even lower on average than the 60%. So we're running at 52.1. I think because of the recent, specifically the recent week and what we are seeing now, that will be higher. But it is a very challenging thing to manage. And we work on it every 2 hours, basically. We talked a little bit about the transfers between ED and UCC. We want to see, what we want to see is patients being seen at the right time, the right place for the right care. And because of the pandemic, we've had some regulatory flexibility that allows us to move patients, especially from the ED to urgent care, easier than we had before. And of course, our teams in the ED and urgent care have worked and reworked workflows so that we are really sorting patients in the best way possible. What we would not want to see during this surge is more patients who might have gone to primary care visits actually presenting to either the ED or urgent care because they couldn't get in. But I just wanted to reassure you that the primary care clinics and the specialty clinics are trying to prioritize patients who are coming in for urgent needs so that doesn't happen. But the flow between the ED and urgent care has really never been better because of the pandemic. And the way that urgent care has set itself up in the lobby, we're actually planning on continuing in some ways permanently. So as we redesign our Building 5 lobby, we're learning from the patient flow we've had during the pandemic and making it, more of a permanent thing because it seems to work better that way. And then the only other thing I want to comment on is what we talked about, the lower level of care. So we have seen that go up. In spite of it looking relatively flat here, as you commented on, Dr. Green, it has gone up in the last couple of weeks. And that's specifically because of the challenges we've had with discharging patients, especially to skilled nursing facilities, because those facilities, including Laguna, have had outbreaks and staff shortages. So we're working very closely with them. Our care coordination team, another remarkable team, has really worked hard to try to get patients to where they need to go. And we're starting to see some of that lighten up. So there's more skilled nursing facilities who can take our patients today than a week ago. So we're just really working hard to get people out when they can be out safely and appropriately. I think, we've talked a lot about most of the surge and what we're addressing. Are there any other questions or anything I didn't address that you'd like me or any of our team members to talk about?
Susan, Dr. Winston or Lisa had a comment in the chat, and I'm just curious. The commissioners don't read that. Could you say that out loud, Lisa?
Sure.
The only thing I wanted to say was I happen to be very familiar with that graph that Luke showed in his presentation because it's the one that we generate based on our morning meeting when we review all the patients in the hospital, which we do 7 days a week. So I think Susan was making the point that for our reporting externally, because the state wants information on folks in med surge and ICU beds. That's what we report externally. But that graph actually represents our internal numbers, and that actually is everyone who's admitted in the hospital who has COVID. And we've been running about 25% of all the patients who have COVID in the hospital are asymptomatic with respect to COVID. About 3/4 have some type of symptom, although in many cases the reasons for their hospitalization are complicated. Sometimes the primary reason is not COVID, but about 1/4 asymptomatic and 3/4 symptomatic.
Yeah, thank you for clarifying Luke's chart. Lisa, I was referring to the one that's in the JCC packet, which is yet again different and shows, like, for example, on January 14th, there being 37 patients. That's just med surg and ICU.
Yes.
So what was in the commit, so what Luke has is had and showed was most accurate for all patients in the hospital, and the one in the JCC packet is just med surg and ICU, and it's what we report to the state. So sorry if all that's confusing to you.
Thank you both for that clarification. And commissioners, I'm going to go quickly to the public comment line to see if anyone would like to comment on this item, which is item 4. Please press *3 if you'd like to make a comment. *3. All right, I don't see any hands, Commissioner, so up to you.
Thank you. Now I'm a little confused about the two numbers. And what are the numbers that we see publicly then from the state or from, the news media saying so many people are in the hospital?
Okay, so let me try this again. Luke showed you a chart that had numbers in the high 60s in the hospital most recently. So today, we count the number was 64. That is every patient in the hospital diagnosed with COVID. That was on Luke's chart. In your packet, there is a chart that shows the most recent number being back on January 14, and it was about 30. It was 37. So this chart here, that one is only med surg and ICU patients.
Okay, so
and that's what we report to the state. So that's why it's in your JCC packet.
Okay, so maybe Mr. Morowitz knows the answers. When we see the hospital numbers in general from the city, I know we asked this before, and I thought that it was, first of all, inclusive of all who had COVID, but it was our understanding that it was inclusive of all patients. Is that correct? Is that another series of numbers that we're seeing?
I don't know, and I can find the answer out for that for you, Dr. Chow.
Okay, I think it'd be good to understand. I mean, each set has a reason, and there would be a reason to understand the set that the director shows us as versus, these numbers which are specific for the hospital, and it becomes clearer now that, as I said, I had thought ICU and ward meant all the people not in the hospital. I mean, not in the ICU, but it means only med surg. That's what you're saying. Okay.
Right, and I am sorry I can't help because I'm not sure the numbers you're referring to, but we can work with Mark offline and.
Yeah, those are the
Sure,
ones that come out of the director when he's looking at total numbers in the hospital. And it might be that they're taking the big numbers that you have rather than the smaller numbers that are related to what the state says they want. So not sure then what the state reports, but I don't think that's where we can get into. Commissioner Green, are you just as confused as I am? Or,
Well, I'm trying to do the math, and I guess I'm not very good at math. But I have the CPMC numbers, and in fact, I looked at them from today, and 40% of the people we have in house today have COVID as their primary diagnosis, and I think we have 60 some. So I think if we have 60 total, I suspect just extrapolating that what we're getting on our graphs are probably total numbers as opposed to just med surg and and ICU. But it's a really good question because it obviously has so many implications for staffing, et cetera. But those are the numbers I have from our place. So there aren't that many institutions to add in.
Yes, true. Okay, thank you. I suspect there are total numbers too, because I think that's probably what the you know what I think the director wants to look at in reports, and certainly the graphs that were being shown, right, show the total capacities of hospitals rather than just simply med surg. I think, but I think we probably need to clarify that.
I'll take care of that. Are there any other questions you all have about Dr. Ehrlich's report?
What I was concerned about was, and this is something that is going to come out after the public health emergency is over. It's that some of the lessons learned, whether or not we're going to be able to carry them out, because obviously you've now created a very efficient and probably more, you know, um, patient-centered system between the ER and the urgent care. I mean, those people who didn't have to wait 3 hours in order to see the ER doctor, who could have been seen over at urgent care in half an hour, and be appropriately taken care of. So, what are the potentials for lobbying in regards to changes of rules that would allow us to continue to do that?
Well, I think the first thing is that we want to extend the regulatory flexibility we have as long as possible. As long as we have COVID patients or the potential for COVID patients in the hospital, we really need that flexibility. So another area, for example, where we use the flexibility in a very fortuitous way is on H52, where we have our acutely psychiatrically ill patients who also have COVID. And that's a really important area for us to be able to use because of the safety issues and patients who may or may not be able to mask appropriately. So that's another area of regulatory flexibility that we need to continue. So in general, regulatory flexibility as long as possible. And that's what hospitals in general in the state and in the nation are lobbying for. Secondly, we've been thinking for a long time about specifically the front end and how we continue to sort patients who show up for urgent or emergent care in the best way possible. And I do think that we've learned some lessons that we will continue to be able to use even when the regulatory flexibility expires. And for that area specifically, it's the EMTALA rules that require medical screening exams to be done for patients who present. I feel pretty confident that we'll still be able to learn from the experience we've had as time moves on.
Very good, thank you. I'm aware that there is a significant amount of lobbying, for example, in seeing whether or not we can maintain telehealth, and it's only mental telehealth that actually has, as you know, received a regulatory, I guess, a permanent regulatory change. I'm just as hopeful as you're saying if the hospitals can obtain regulatory relief from those things that really are found to be working. That would be a nice byproduct of this terrible pandemic.
Well, and there the issue is getting paid for those services mainly. So, and we have been successful on that for the most part, but that will continue.
Okay, very good. Does anybody else have any further comments on this item? It's very important, and thank you so much for the update of what San Francisco General here is doing. I think I can speak on behalf of all the commissioners. We're really very grateful and now very impressed with the amount of thoughtfulness and the dedication of both the medical, nursing, and everybody else who has been, challenged by this and working as hard as they have. So
we really appreciate your support, and I can't. It's hard to express in words what a remarkable team we have here. Absolutely everybody, and I'm really grateful for that. So thank you for your support.
Great, and Mark, maybe we could sum this up in a nice way so that the commission will also be able to hear it when we, present the Zsfg report, because
Sure. And Dr. Day, is it possible to send me those slides?
Of course, I'll send them to you right now.
Okay, thank you. That'd be helpful. Great. All right, let's move on to item 5, Zsfg hiring and vacancy report.
Okay.
Thank you, Mark. Good afternoon, commissioners. To close out 2021, the December vacancy rate increased to 9.7%, with the RN vacancy rate up at 5%. We hired 37 employees in December through continuing challenges of the migration of data from the old applicant tracking system to the new one that's called Smart Recruiters. For nursing, we filled 27 P103 positions last month to assist with operational gaps. And in early January, we sent out a survey to P103 nurses to see if they had any interest in a 2320 position. We will be conducting outreach to each of the 86 respondents to assist them with the application process on Smart Recruiters. Commissioner Green had a few follow-up questions, so let me try to address those. At this point, we're unsure how many will end up applying to the recruitment and meet the minimum qualifications, as we just asked for their interest. Next month, we will have more information after follow-up by the recruiters, and this will allow some time for Merit to review their applications. Should they be selected for a 2320, they may stay in their current unit if there is a 2320 vacancy in that unit, or they could be selected for another unit. And their hours would increase from a per diem as needed to a regular shift, which will improve staffing levels. On a positive note, we hired an additional recruiter starting this week to assist with outreach efforts for those difficult to fill positions. And for an update from mental health hiring, our update is that 84 already started and or are onboarded. Another 154 are in the selection process right now. Most of these positions will not be located at ZSFG. New to the ZSFG budget this year were the BERT positions. And as a hiring update, HR and leadership are partnering closely to fill the positions and prioritizing BERT vacancies. HR is onboarding via the expedited hiring events, that one-stop fingerprinting / medical events that we have twice a week at the hospital. And an update on hiring. For the 6 RN BERT nurses, 4 selections were made from the internal psych unit, and the final 2, the hiring manager is making selections this week from the external applicant pool. For the 14 FTEs 2305 psych techs, the hiring manager made 3 selections this week, and we are targeting February 19th for a start work date. We have a continuous job flyer up, but thus far, not many applicants. We've received 4 applications this month. For the 8 2312 or LVN positions, the hiring manager has applicants and is making selections this week. Again, targeting a start work date of February 19th. The JCC summary report still reflected the original 2305 vacancies, even though we modified those 8 to LVNs. That will be updated on the next month's data. And then Commissioner Green, you asked about a chart for new positions. I wasn't sure if you were asking for a BERT chart on hiring or DPH overall for mental health, because that's where the majority of the positions are funded out of a different, not out of ZSFG. And then, so I'll let Commissioner Green ask me clarify that one in a minute. And then also I have a question for the commissioners. If you could confirm on the charts for next month when we report out, since we'll have one more year, if you are ready to retire the 2019 data on the bar graphs and the graphs, because we will already have 2020, 2021, and now 2022 to report on. So that's just a question if you would like to remove the 2019 for future reports out. And now I'll go to any follow-up questions.
Mark, shall we ask for public comment?
Sure. Person on the line, if you'd like to make comment on item 5, please, the HR and vacancy report, please press *3. No hand, commissioners.
Thank you. I'll ask Commissioner Green if she wants to respond to the response to your question.
Oh no, I always like to look at the vacancies and, um, but the vacancies are a proportion of established positions. And if there are certain areas where we're opening up the number of positions, then as you compare year over year, if you don't know that there were that many more positions, it could look like that many more vacancies, especially if they can't be filled expeditiously. So it was just a matter of context. And if they're all in mental health, I think we can follow that. And I appreciate your answers were really clear. And it's exciting to think that they've had that many applicants because that was our big worry. We've got the funding for these mental health positions. Do we have the manpower to fill them? Do you have any sense of, as you look at these people in the recruitment pipelines, do you have any sense of the percentage who actually will qualify and that, how many do you have to see to distill it down to the ones that actually are going to be able to, be employed?
Are you talking for mental health or for the P103 applicants?
Well, kind of both. I mean, I'm just
Okay.
curious to know whether, I mean, because in the past with mental health, we've had all these stipulations and, we've talked about at what point do you bring it down to licensed social workers, which is great that the LVNs have come into play because I think that's such an excellent expansion um, of the pool of possibility.
Sure. It completely varies on the classification. So for the mental health hires that we're doing at central office, the majority are in the health worker series. So they're health workers, and we have a large candidate pool for that. That's why it was quite easy to make those selections. And honestly, majority of those in the higher classifications are internals taking an opportunity for promotion. So this is fabulous for our internal employees to get that opportunity. So for the mental health hires that we're doing collectively across DPH assisting with that 267 or so positions, those are fairly easy to fill. Now for the BERT team specifically, the 2305s, that is that classification that we do not get a lot of candidates for. And so that is a continual challenge. And that's why we did modify some of those LVNs. I know that the BERT leadership team at the hospital is open to modifying more of those positions to LVNs. We wanted to see what we could get with this first push, see how these LVNs do. I'm based on what we're seeing, I don't see how we're going to be able to fill the rest with 2305s. We're just not getting the applicants. For the P103s moving to 2320s, historically, we have not had a lot of success. They either choose not to accept the position because they're happy with their external P103. They have a full-time job elsewhere. So, we have to compete with that. And they may be interested in a position that they truly don't meet the qualifications for. So that's why we're going to do some hands-on, kind of walk them through, make sure before they follow, they apply to the specialty unit they were interested in, that they truly meet the minimum quals. Because we have a big drop-off with nurses interested and qualified. There's a big drop-off in that data. So we're hopeful that we can get even a portion of those 86. That's a huge win for us. So, we'll have a little more data next month. I'm looking forward to giving some good news on that. And for BERT, I should have a lot more updates on that next month because the manager does have the candidate pool for LVNs. And we'll see if we've made all of our nurse selections, which shouldn't be a problem.
Well, that's terrific. The one other question, again, this is maybe another crystal ball question, but in terms of, the attrition of nurses in particular at at hospitals in general, do you feel that we've kind of reached the nadir? In other words, people that were teetering on the brink of quitting or retiring and then COVID hit and that they're kind of gone, or people that moved away? Or do you think we have another wave of people who will, step back? Do you have any sense of that? And when people do leave without retiring, do we know, are there any commonalities to their reasons? Do we do exit interviews, and do we know anything about that?
We do exit interviews. We are going to be doing a deeper dive upcoming into the separations. So we're working on, for next month, we plan on looking at with you diversity. So we've been looking at diversity of nurse hiring, where we're at with that. And our next look is at separations, where they're at, what units, what was the reason provided, kind of those trends, and or where, you know, just where are we losing people? Is it right after they start within 3 months? Is it the longer term? So there's a lot of data to look at. We haven't done that deep dive into that data. So as far as what we're seeing for retirements, we're not seeing a large number of retirements right now. It's fairly stable and flat. So that doesn't appear to be an issue. But certainly if the hospital admin has any, you know, from their experience working if Terry's on the call to share if she's still losing nurses to take travel nurse positions or external P103s. I'm hearing some of those from managers that they still have nurses leaving for those opportunities outside of Zuckerberg.
Thanks, Carrie. This is Terry, and we do have a lot of nurses that are leaving. We just found out today that one of our nurses who applied for reassignment from med-surg to labor and delivery is going to another hospital to accept a $20,000 sign-on bonus, which she will have to work there 2 years in order to get that. We just had 4 ED young nurses leave, and they're going to go traveling once again to get bonuses. We're learned about this generation of nurses that pension and things like that are not important to this group at this time. And so a lot of people want to see the world, make money so they can enjoy the world. And we are really looking as a city, the CNO group for the hospital council, we're really working together to see how we can get nurses to come, because we each have a niche. And we're really working very closely together to ask the schools to form residency programs to meet the needs of the hospitals, and to really have the schools, USF, San Francisco State, City College, Dominican, all meet the needs of the hospitals and what nursing is doing today, as opposed to curriculum that may not be as up to date. Hope that helps.
Very much, thank you.
I also just want to add, you know, one thing. I mean, this is obviously a national phenomenon. Healthcare workers being unhappy, especially nurses, with their working environment. But we do have something that in the state of California that no other state in the union has, and that's nursing ratios. And that is a really big draw for nurses. It's a really big safety, you know, issue for nurses, and it's a satisfier for nurses. So, you know, I don't know how long this trend will last with nurses traveling and going other places, but it is important to note that in California, we do have that really important draw for nurses, especially here.
Good. Yeah, thank you. I think the question that came up also was whether or not we needed the 2019 data. And of course, if we were looking at med-surg and all, you can always congratulate yourself because we had our biggest vacancies during that time. But I'd ask Commissioner Green if she has any preference, or that we just keep the, I guess, the 3-year cycle route, and therefore we drop 2019.
Well, thank you for asking. I mean, I'd be happy to drop 2019 and just go with the 3 years.
This is Terry. I'd like for one consideration is you may want to keep it because we are going into bargaining, and it'll help you to look at when we start getting comments. That data could be retired in June, perhaps.
Okay, why don't we revisit it in June again? Thank you for your suggestion. And would that be okay? We'll revisit that in June, and at that time make a new decision.
Yeah, that's fine. And just let us know next month if you have trouble reading it. Well, may have to we might have to make one graph per page or something and adjust it just so it's readable.
Yeah, it is. You're right, especially the bar graphs.
Right. No problem. We'll work on making that a little more visible.
Okay.
Thank you.
Thank you.
Is it okay to move to the next item, commissioners?
Let's make sure there are no other comments from our group here. And I didn't see any from hands. Did you see any? Okay, so why don't we move on to our next item, please?
Sure. Item 6 is the medical staff report. Dr. Winston.
Thank you very much. Good afternoon, commissioners. So the first item that I wanted to present to you is the clinical service report from the Department of Surgery. And our interim chief, Dr. Joseph Kucheri, really gave a beautiful report going through the faculty, the many honors that they have gotten recently, the scope of their clinical services, which, you know, has really been very impressive. And then I think a really comprehensive description of their process and performance improvement. But Dr. Green, I think, did have some questions about one part of the report, which was specifically the satisfaction surveys by the faculty, which Dr. Kucheri certainly highlighted during the presentation to MEC as an area for improvement. So I just wanted to go through those specific questions and then a couple of other questions. Dr. Green, I think you were wondering when the survey was conducted. And it was conducted in March of 2021. That's when all of the responses came in. And I think you were wondering, you know, given the leadership and the prominence of the department, you know, was there any insight into why the burnout was high and the satisfaction with leadership was low? And I think that you know, despite the many accomplishments of the surgery department, they have had some challenges with unstable leadership over a period of years in terms of, you know, having a chief who was a permanent chief for a long period of time. And prior to Dr. Kucheri taking over in August as the interim chief, the prior chief, Dr. Stein, was with us for 2 years. And, you know, she did a lot of wonderful things, but I think that, you know, one of the things that came through in the satisfaction survey was just that there were some issues with communication and other things where the faculty maybe did not feel as heard as they had hoped. And that's something that Dr. Kucheri is specifically working on. But he did agree with you that, you know, in terms of the nature of the specialty, that dealing with burnout and stress is very high among surgeons who specialize in trauma and emergency surgery. And that, you know, probably contributes to the data that you saw. And then there was some question as to whether there were differences in responses amongst in-residence clinical and courtesy faculty. The data here do not, they're only for the on-site active faculty. This wasn't including residents or courtesy faculty, and there actually weren't, all of the surgery faculty are clinically active. So Dr. Kucheri did not notice differences, you know, amongst the surgeons who have different roles. And then there's a question about countermeasures being developed. And I think these are really very robust. First of all, I think that Dr. Kucheri has really done a fantastic job kind of stabilizing things within the department. And he says that the leadership here and with the UCSF Department of Surgery, they're well aware of all the concerns. And everyone is carefully following and tracking wellness and satisfaction, including at our dean's office. And I'll just give you an opportunity to see if you have any questions, and note that Dr. Carlisle is also on from the dean's office, you know, in case you have any questions that she may be able to answer.
See, Dr. Carlisle, why don't you make some comments? I'm not sure if you're muted or not muted, or you just like to wave your hand.
I just unmuted.
Thank you.
I think that Dr. Winston covered the issues extremely well in terms of the effect of the turnover in leadership on the well-being and morale in that department. And I am absolutely confident that we're on the upswing in that respect, and have great confidence in our new leadership. We are about to launch a search for which we must do for a new chief. I have been told by Dr. Cucchieri when he took the interim position that he is very interested in applying for the job as the permanent chief. And I hope that this 6 months that he has been has not changed his mind about that, because we would dearly love to have him in the applicant pool. So we will start that search probably early March.
How long has it been since he has come as interim? And I can't remember exactly.
I'm sorry, ask it again.
How long has he been interim?
He started in August.
Oh, okay. So it's not even a year.
No, it's just coming up on 6 months pretty soon here. He was hired as the director of trauma, and to replace Bob McCursey, and was in that position before he took the interim position as the chief. And he's maintained that, but also delegated some of the responsibilities to some of his other faculty members, even though he's retained the administrative capacity to lead that team.
Thank you. Let's see. Dr. Winston, you are continuing your report, and then we'll ask for public comment.
Perfect. Thank you so much. Dr. Green just had a couple of other questions. One was very specific. There's an abbreviation in the service report, IPV, and this gets abbreviated different ways, but the abbreviation we use here is IPV for intimate partner violence. And I think that maybe one of the reasons why it was confusing is the section H on IPV didn't define it, but further up the page it does say what it is. But as I'm sure you know very well, there are a variety of abbreviations that are used to describe that. So, but that is what it means here. And then I think the last question you had, Dr. Green, you know, given that one thing described in the report was the no-show rate in the surgery clinic, was whether there is a uniform approach across all departments to address the no-show rate. And fortunately, we have someone who is an absolute expert in that topic here with us, Dr. Luke John Day, and he has graciously volunteered to answer that question.
I don't know if I'm an expert, but there are many more experts on campus here. But it's a great question, and it's one that we've been working on probably for the last 5 years, and that's really how do we reduce no-show rates in our patient population. And so we've taken a very systematic approach across all of our specialty care clinics on this. So first one, ensure we all use a standardized definition of no-show, so how we track it and how we record it and pull it from Epic. Second, we pull those reports and share them with all of the services on a monthly basis. And so each of our clinics receive that data. And then we give them a standardized toolkit that they can use with proven best practices on how to reduce no-show rates. And so things such as calling patients and ensuring we talk to them when we schedule an appointment, doing confirmation calls, essentially making sure that we talk to a patient, reminding them of the appointment, but doing some prep work. Also leveraging technology such as apps and MyChart for some of our patients. Those have been incredibly effective in terms of a universal approach. And then some clinics have used more tailor-based approaches to reduce no-show rates within their individual clinics.
Thanks.
Thank you. Shall we ask for public comment?
Sure. If you'd like to make a person on the line, if you'd like to make comment on item 6, the medical staff report, please press *3. No hand, commissioners.
Thank you. I appreciate Dr. Green's questions because I had written one or two of those down and we've answered the question of leadership and when we were going to be recruiting. I'd like to ask on trauma surgery report, that's on the bullet point on trauma surgery. There was a note that there was increasing growth of the geriatric population. And I didn't actually see a reason, and it says it's ongoing intense evaluation. So was there some verbal reason given that they believe that this is occurring or that we're having more trauma within that age group? And at the same time, just right under it is the question of race and ethnicity. And I know that when they pointed out 40% were Caucasian, but it was not broken out in terms of a Hispanic race ethnicity. And would sound like that's fairly important to do. And how do we actually do that? Or is it possible to be done within their data?
Yeah. So I will say it was amazing the amount of data that Dr. Cucciari went through during his service report. I was just so impressed by everything that he had pulled together in a relatively short period of time. I don't recall a description of why they thought they might be seeing an increased number of geriatric patients. And I can ask him about that. And in the summary here, we don't have the specific graphs of the ethnicity breakdowns, but I think that is something that can likely be provided if it would be of interest.
I think because we're looking at a question of equity and whether or not you have enough data to be able to target the key issues, that's why I'm asking on the geriatric and also on the ethnicity, so that there'd be areas that perhaps need attention. So.
Yeah.
We can speculate on the geriatrics in that I think that with the pandemic, there are more people getting bored and doing things like climbing ladders and falling off. And in fact, the data nationally show that the most of the geriatric injuries are from falls of various sorts. So that's my speculation on that one.
No, that's fine. And like I said, since we're working on the issue of equity, I think it'd be important, and you don't have to report back to us, but I would hope that in the future report, they would be able to look more carefully, at least more in depth, since they did comment that they did not break out the Hispanic group, which seemed like, since you pointed it out, that was perhaps the larger number of the people within the population base.
Yeah, Dr. Chow, I will definitely take a look at the original slides. And if there is more information in the slide set, can forward that to Mark for review, and I'll try to highlight where to look. But I can also certainly pass along that that will be of interest to highlight in future reports.
Sure. No, thank you very much. Does anyone have any further comments at this point? Did you want to then go on to the other part of the business that I know you have for us?
Yes, thank you. So there are two items for your consideration for voting. One are the surgery rules and regs that were updated with the clinical service report. And I believe you received both the track changes version and the brief summary of changes, which were relatively minor. And then the other item to consider for potential voting is the standardized procedures from the anesthesia, NP, and PA. And you may recall we actually discussed these in December, but then it turned out that they had not made it onto the formal agenda, so they were not able to be voted upon. So that's why they've come back for a vote at this meeting.
Okay, so I think we need a motion to accept the changes in the rules, regulations.
Move to approve.
And that would be for all of this, right?
Correct, yes.
Okay, and I would second, and we therefore have approved them.
Great, thank you. Thank you, Dr. Winston. We can move on to item 7, which is other business. Folks on the line, the public comment line, if you'd like to make comment on other business, press *3. All right, no hands, commissioners. I don't see anything from you, so we can move on to public comment.
Okay.
Folks on the line, this is your opportunity to make a comment about something that's not on the agenda. Please press *3 to do so. I'm seeing more people there, so I'm going to wait a second, everybody's, to make sure that we're not going to miss anyone. So again, please press *3 if you'd like to make comment on general public comment. All right, I don't see any hands.
Okay, so I guess we can go on to the next item.
Yes, closed session, a consideration for a closed session is the next item.
Okay, so we need a motion on whether to hold a closed session.
Move to go to closed session.
Would second that. So we will then go into closed session.
Yes, if you give me 30 seconds. Folks on the public comment line, you will not be able to take part or listen to the discussion, but we will be coming back if you want to hang around. Everyone else, please give me 30 seconds. Okay, we are back in open session. Before we move forward, I want to note that while we were in closed session, a few folks, one person on the public comment line raised their hand. And so I'm saying this to the public record that that we apologize. I tried to make space and time so that we would capture any delay in the remote meeting. And I'll try to do better in the future, but I'm just noting that those folks did want to make comment. All right, commissioners and everybody, it's now time to consider whether to disclose or not disclose discussions held in closed session.
Move not to disclose.
So there's a motion not to disclose. I would second that motion.
All right, so that means it passes. Thank you. And then now a consideration for adjournment.
Move to adjourn.
Well, okay, I will second that. Thank you, everybody, for a very efficient and a very useful meeting for all of us. And we will see you next month. Thank you.
Thank you, commissioners.
Bye.